Laboratory tests play a pivotal role in the diagnosis and ongoing management of diabetes. From initial diagnosis to long-term monitoring, tests like fasting blood glucose level, HbA1c, and oral glucose tolerance tests provide crucial insights into a patient's glycemic status. These tests help physicians tailor treatment plans, assess response therapy, and identify potential complications. By leveraging the utility of laboratory tests in the diabetic care, healthcare providers can empower patients to take control of their health and achieve better outcomes in managing this chronic condition. I request Dr. L. Madan sir, who did his MD in pharmacology and professor and head of Department of Pharmacology in Coimbatore Medical College, to introduce the speaker and chair this session. The speaker of this session is Dr.N. Dheebalakshmi ma'am, professor and HOD of Department of Biochemistry in Coimbatore Medical College.
Good afternoon and all. It's very PG experience publication with five numbers. So the lab tests which are going to utilize and management of diabetes mellitus, already mentioned that's the old previous, the fasting blood glucose and postprandial blood glucose level. Then OGTT is available test 10 years back. Now the various tests are available to diagnose and management and find out the comorbid condition also. So now this lecture going to be very useful to the newer any lab test regarding to treatment and management of the diabetes mellitus. Now over to Dr. Dheebalakshmi.
Thank you, sir. Thank you for the introduction. So let us move on to the topic proper. Actually, the topic I have decided that topic pointing towards precision medicine and the role of precision medicine in diabetes or precision diabetes medicine. So I'll try to cover at least a few area related to precision diabetes medicine. So what is precision medicine? Is it a new one? It's not a new one, right? Then where it has been practiced? So the classical example what we can give is, before blood transfusion, we used to do blood grouping, typing, cross-matching, all those things. So that itself is considered as a best example for the precision medicine. And also the evolvement of the human genome sequencing leads to a dramatic improvement in the precision medicine. And also the availability of all these omics also leads a path towards the precision medicine. And what is the effect of precision medicine? Actually, precision medicine means precision medicine, or the other terminology, personalized medicine. So it is generally the common meaning of this, what I have understood from various articles is right time diagnosing to the right patient and giving the proper or appropriate treatment to the patient. So, and what is the role or effect of this precision medicine? It mainly enhances our ability to characterize, understand the human biological variations through means by analyzing the patient in various manners. That is with the help, metabolic status and assessment of his genetic status, and also based on all these data, we are coming to a conclusion towards the decision of making the treatment decision. So, okay. So that is a role of precision medicine, what I have observed. And also this precision medicine aims to move away the generalized approaches. Okay. And this is mainly based on the individual's variability in genes, environment, and lifestyle. Next. Okay. So the major distinction from the standard medical approach towards this precision medicine is the use of the complex data to characterize the individual's health status, predisposition, prognosis, and also likely the treatment response. And this thing is very, very important. See, this precision medicine also focuses on identifying the patients who, despite a diagnosis, do not require treatment. So that is very, very important. We can give some examples related to diabetes mellitus, types of diabetes mellitus later. Next, pa. So a small or a brief intro about the classification of diabetes. Previous slide. So diabetes, as of all of you know, they're classified into type 1 diabetes, type 2 diabetes, type 1 diabetes due to autoimmune beta cell destruction leading to absolute insulin deficiency, and type 2 diabetes due to non-autoimmune progressive loss of adequate non-autoimmune, but during over a period of time, it leads to progressive loss of adequate beta cell insulin secretion. So initially it starts with insulin resistance, and later there will be beta cell failure to secrete the insulin. Next. And also we have a specific type of diabetes due to other causes, which previous slide, which needs some attention, that is monogenic diabetes syndromes. Monogenic diabetes syndromes, towards this monogenic diabetes syndromes only, the precision medicine is focusing. So under this monogenic diabetes syndrome, we have neonatal diabetes and maturity onset of diabetes in young, which is abbreviated as MODY, M-O-D-Y. And also we have syndromic diabetes. And the other causes like diseases of exocrine pancreas or drugs or some chemicals also may induce, or prolonged use may induce diabetes. Next. And of course, we have gestational diabetes. You all know the meaning of this gestational diabetes. Next. So from this classification, I hope you would have understood that, yes, there is some type of classification that is monogenic. That means we have other entity like polygenic. So polygenic means the heterogeneous. So various genes will be involved. So the type 1 diabetes and type 2 diabetes are considered as heterogeneous diseases, and they were not present as such what you are learning regarding to the classical signs and symptoms of diabetes. Not each and every patient will present with the exact clinical signs and symptoms. It may vary from patient to patient. Next. So regarding type 1 diabetes mellitus, usually children with type 1 diabetes, they present with this hallmark symptoms of polyuria, polydipsia, and also some of the patients may present with GKA. In adults, the onset it's more somewhat variable. I am not telling about all the adults presenting with diabetes. Few patients may present with various symptoms. They may not have the classical signs and symptoms. Okay. Next. And we have certain features which is most useful to discriminate the type 1 diabetes. What are they? Younger age, very young age, that is less than 35 years with low BMI, unintentional weight loss, ketoacidosis, and plasma glucose level more than 360 milligram per deciliter. If all these 4 are present in a patient while they are presenting to the clinics, we can consider the patient is having type 1 diabetes mellitus. Next. So type 2, it doesn't mean that type 2 diabetes mellitus patient won't present with DKA. So usually we used to learn the DKA, that is diabetic ketoacidosis, is the acute complication of uncontrolled type 1 diabetes mellitus, but yet this DKA can be presented in some of the patients with type 2 diabetes mellitus also. So it is very important for the healthcare professional to realize that classification of diabetes type is not always straightforward at presentation. So this we have to keep it in mind. Next. So sometimes misdiagnosis is common. Misdiagnosis. So what is mean by that? So adults with type 1 diabetes can be misdiagnosed as having type 2, and individuals with maturity onset of diabetes in young misdiagnosed as having type 1. So this needs some attention. So here comes the role of precision medicine. So here we have to apply the relevant investigations on the patient according to the clinical signs and symptoms. So there comes the role of precision medicine, and in the previous speakers, they told about the clinical intuition. So keeping that the clinical intuition in our mind, we have to ask for the relevant investigation so that we can corner or not corner, we can come to a conclusion whether the patient is really having type 1 or MODY, which type of MODY, and the appropriate treatment can be given. So that is the role of precision medicine now. Next. So we all know that to diagnose the type 1 diabetes mellitus, you would have learned about the presence of autoantibodies, various types of autoantibodies. So what the studies say is persistence presence of 2 or more islet autoantibodies is a near certain predictor of clinical diabetes. And of course, plasma glucose level and HbA1c. So these two levels will rise well before the clinical onset of diabetes. So that's what usually we used to teach the students, that if the patient is diagnosed on a particular day, so for example, today as a diabetic patient, it doesn't mean that the patient is having diabetes from today onwards. So all the processes would have been taken place in the patients 5 to 10 years back. So before the onset of clinical onset or presentation, the patient's glucose, plasma glucose, and the HbA1c levels may increase. So some studies have given 3 distinct stages of type 1 diabetes. We'll see in the next slide. Next, ma. So there are 3 distinct stages. So stage 1, 2, 3, and 3. In all the 3, so in 3 stages, there will be the evidence for autoimmunity by through the presence of or identification of the autoantibodies towards various compounds. So what is the diagnostic criteria for stage 1? So stage 1, presence of or identification of multiple islet autoantibodies, and there is no evidence for what is IgT, impaired glucose tolerance, or impaired fasting glycemia. But in stage 2, the evidence for autoimmunity is present, and the patient will be having dysglycemia and pre-symptomatic. And in stage 3, autoimmunity, the autoantibodies may become absent, but the patient will be exhibiting overt hyperglycemia and diabetes. We have to diagnose at the stage 3 level. We have to diagnose the diabetes by the standard criteria that we have. What is the standard criteria we have to diagnose diabetes? Fasting plasma glucose more than or equal to 126 milligram per deciliter, or 2-hour post-load plasma glucose more than 200 milligram per deciliter, or random plasma glucose more than or equal to 200 milligram per deciliter along with classical signs and symptoms. Next. So how diabetes mellitus and laboratory are connected. So laboratory, I'm not just meaning about biochemistry alone. So while evaluating a patient with diabetes, we used to do all these investigations. So as a common, all the laboratory medicine itself involved itself in diagnosing or screening the diabetes mellitus. Next slide. So for screening, we'll be doing all these parameters related to plasma glucose level, HbA1c. If in case, if necessary, we have to go for oral glucose tolerance test, and also to monitor the progression of the disease or the plasma glucose status or the glycemic control. We have to go for HbA1c analysis and urine analysis. Then prognosis. Prognosis mainly to check whether the patient is developing any impending complications in terms of all these parameters, which points towards the organ function test like liver function test, renal function test, other enzymes. And etiology, so that is also very important. So all these parameters will be dealt by our clinical biochemistry. Next. So as I told you earlier, the presence of autoantibodies, and we saw a few features which can discriminate type 1 diabetes. The most important one is presence of autoantibodies to all these things: islet cell cytoplasmic antibodies, GAD, insulin, all those things, zinc transporter 8 and all. Next. But type 2 diabetes is diagnosed based on the plasma glucose criteria. That is either fasting plasma glucose value or 2-hour post plasma glucose during a 75 gram OGTT or A1C criteria. But generally, this fasting plasma glucose, 2-hour post-load glucose, and A1C are equally appropriate for diagnostic screening purpose. Next. So this criteria I have told you already. Next. So, okay. So this was quite interesting. That's why I just displayed this slide. Regarding the fasting plasma glucose and 2-hour post-load plasma glucose, there must be the concordance between the fasting plasma glucose and the 2-hour plasma glucose. When they analyze the concordance between these two, it seems to be imperfect. But there is a good concordance between the HbA1c and either of the plasma glucose, either HbA1c and fasting or HbA1c 2-hour plasma glucose, 2-hour post-load plasma glucose. So in case of any discordance between the HbA1c levels and glucose values, fasting plasma glucose and 2-hour plasma glucose, post-load plasma glucose are more appropriate. And for the analysis of HbA1c, to avoid the misdiagnosis or missed diagnosis, the HbA1c test, HbA1c analysis must be performed by using a method which is certified by National Glycohemoglobin Standardization Program. Next. Okay, and regarding the HbA1c, I hope you all know about the importance of HbA1c. This will reflect the plasma glycemic control over a period of last 3 months period. But yes, the HbA1c value itself, HbA1c itself is influenced by various factors. What are the factors responsible for or not responsible? What are the factors that can have an impact over the HbA1c levels that we'll see? Next. What are the next? Then we'll come to the previous. Yeah. So the HbA1c, these are the factors that can have an impact or influence over the HbA1c analysis. It has its own advantages. What are all the advantages of the HbA1c analysis? A slide coming up. Okay, so what are the advantages? So though it has some influence by the other factors, but HbA1c has several advantages. What are all the advantages when compared with the fasting plasma glucose and other 2-hour post-load plasma glucose? And it's of greater convenience. Fasting is not required, and it has greater pre-analytical stability and fewer day-to-day perturbations during stress or other nutrition or illness-related thing. But in some cases, an imperfect correlation between A1C and average glucose is noted in some individuals. But altogether, there must be concordance between the HbA1c and either of the plasma glucose level, and HbA1c must be analyzed by a specific method, which is reliable method, which must be a reliable method. And though HbA1c is influenced by various factors, it has its own advantages. Next. So I have mentioned few factors that can influence the HbA1c level. Regarding age, recent ADA clinical guidance concluded that HbA1c, fasting plasma glucose or 2-hour post-load plasma glucose could be used to test for pre-diabetes or type 2 diabetes even in children and adolescents also. And one of most important one, hemoglobinopathies. Hemoglobinopathies, which is associated with the related to hemoglobin, related to any derangement or defect in the hemoglobin structure. No, so in one of the hemoglobinopathies where the variant hemoglobin is present, but normal red blood cell turnover is present in case of sickle cell trait, HbA1c assay can be done without any HbA1c assay we can use. Next. So in case of certain conditions where there is increased red cell turnover, like sickle cell disease, the previous one, what I have quoted is sickle cell trait, but here sickle cell disease in pregnancy, especially 2nd and 3rd trimester, glucose 6-phosphate dehydrogenase deficiency, hemodialysis, recent blood loss or transfusion, and erythropoietin therapy. So if in the presence of either of these factors associated with increased red blood cell turnover, we have to use only the plasma glucose criteria to diagnose the diabetes mellitus. Next. So we have various methodologies for HbA1c analysis, but in our clinical biochemistry lab at Coimbatore Medical College Hospital, we do HPLC procedure to evaluate the HbA1c, and we have all these methodologies available. Next. Enzymatic methodologies, enzymatic analysis also available to evaluate the HbA1c. Next. Okay, so HbA1c is less reliable than plasma glucose measurement in case of postpartum state and HIV treated with these types of inhibitors and also in iron deficiency anemia. Next. So then how to diagnose? So a patient in a hyperglycemic crisis, that means the patient is having hyperglycemia with classical symptoms related to hyperglycemia, that is polyuria, polydipsia, all the other related symptoms, and the random plasma glucose of more than 200 milligram per deciliter. If this is present, yes, the patient is a diabetic. So that is the criteria that we have to follow. When there is no evidence of clinical signs and symptoms, then what we have to do? Then diagnosis requires two abnormal screening test results, either from the same sample or in two separate test samples. That means in conditions where the patient is not having the relevant appropriate clinical signs and symptoms. So that time we have to rely on two abnormal screening tests. For example, if the HbA1c of one blood sample is 7.0 and a repeat result is again 6.8%, then the diagnosis of diabetes is confirmed in those types of patients. Next. Okay. So if the patient has discordant, which no concordance between two tests, then the test result that is above the diagnostic cut point should be repeated with careful consideration of the possibility of A1C, which also confirms the diagnosis. That was I have quoted the example in the previous slide. Next. So here I would like to tell you about the pre-diabetes. You all know the criteria for diabetes. What is the criteria for pre-diabetes? HbA1c lies between 5.7 to 6.4%, fasting plasma glucose between 100 to 125 milligram per deciliter, and 2-hour post-load plasma glucose 140 to 199 milligram per deciliter. So all these three is pertaining towards pre-diabetes. So the next one, already I hope you all know, HbA1c more than or equal to 6.5%, fasting plasma glucose more than or equal to 126 milligram per deciliter, 2-hour post-load more than or equal to 200, and of course our random plasma glucose more than or equal to 200 milligram per deciliter. So this I hope you all know, but you have to concentrate on this pre-diabetes also. Next. So I have told you in the beginning that the precision medicine is focusing towards the monogenic diabetes. So under monogenic diabetes, we have, I have told you already, neonatal diabetes, maturity onset of diabetes in young, and syndromic diabetes. So these three are the most important category that comes under monogenic diabetes. What is mean by this monogenic diabetes? Mainly associated with single gene defect. So we have various types in MODI, but each and every type has a unique, single gene defect or polymorphism is there. Next. Okay, so it's because why we are focusing about this monogenic diabetes is, as I told you in the earlier previous slides, the diagnosing of MODI is misdiagnosed as type 1 diabetes. So for that, we must have an understanding about the monogenic diabetes. We can give some few examples of precision diabetes. What is that? One is diagnosis of neonatal diabetes with these two gene mutation, which has been successfully switched over from insulin therapy to oral sulfonylurea. And also by correctly diagnosing MODI, it is possible to avoid lifelong insulin injections in patients who are wrongly or misdiagnosed as having type 1 diabetes. So monogenic diabetes, yes, we have to focus on monogenic diabetes. That means any type of monogenic diabetes should not be missed or misdiagnosed. Okay, next. And a few points about neonatal diabetes, that is, which is one of the category under this monogenic diabetes. So diabetes occurring under 6 months of age is termed as neonatal or congenital diabetes, and 80 to 85% of cases could be found to have underlying monogenic cause. That is, monogenic cause means single gene defect. That is very, very important. And it is in for some patients it is transient, and some patients it is permanent. So there are two classes available, transient or permanent. How this neonatal diabetes is presented? So it is mainly associated with IUGR, that is intrauterine growth retardation, failure to thrive, polyuria, and also associated with severe dehydration. Next. So a few words about the transient neonatal diabetes, which is abbreviated as TNDM. So over 60 to 70% of in approximately about 60 to 70% of patients, there is overexpression of genes on the chromosome 6q24. So this is very, very notable thing, and may be treatable with medications other than insulin. And in remaining 30 to 40% of patients, the mutations in potassium related ATP channels in these two genes. So for in case of neonatal diabetes, that is a transient or permanent, the treatment is with high doses of sulfonylurea that holds very good. Next. So permanent neonatal diabetes, it's mainly commonly due to the autosomal dominant mutations in the gene which encoding the subunits, that is KR6.2 and SUR1 subunit, representing those two genes which is associated with beta cell potassium related ATP channel. So this permanent neonatal diabetes mellitus is also associated with various syndromes, they say. Next. Okay, and in some articles they have given insulin gene mutations are the second most common cause for permanent neonatal diabetes. So while giving the treatment to the patients, along with the treatment, genetic counseling also plays a major role. Genetic counseling is very, very important, and this area is focused. I mean, this area is mainly focused in the era of the precision medicine. Next. Okay, so the recent ADA and European Association of the Study for Diabetes, Type 1 Diabetes Consensus Report recommends that any individuals, that is babies, regardless of the current age, individuals diagnosed under 6 months of age should have a genetic testing. That means individuals having severe hyperglycemia, having a suspicion of neonatal diabetes before 6 months of age, that is newborn babies under 6 months of age, if there is any suspicion towards neonatal diabetes, yes, we have to go for genetic testing. Next. So why genetic testing? Why we are opting for genetic testing? Because it is associated with, all these comes under single gene disorder, mutation or disorder. So the correct diagnosis has critical implications because 30 to 50% of people with this potassium related ATP related neonatal diabetes will exhibit improvised plasma glucose levels when treated with high dose of oral sulfonylureas instead of insulin. So that's why the treatment is going towards this. So to decide this treatment, we have to go for genetic testing. So that is the idea behind this precision medicine towards this monogenic diabetes syndromes. Next. And few words about the maturity onset of diabetes in young. We have various types of, I'm not giving all those details and all, it's very difficult to go through in one slide. I mean, not difficult means it is not legible that much. So you can refer various textbooks, and also I'll give some references also. So regarding this maturity onset of diabetes in young, it is also comes under the monogenic diabetes associated with single gene mutation. So this MODY is caused by a single gene mutation that leads to a defect in the beta cell insulin secretion in response to glucose stimulation. So after glucose level is elevated, not elevated, after, you all know, after a meal, due to digestion and absorption, plasma glucose level will be elevated, and as a result, insulin is released. So that area is affected in case of MODY. So most genetic versions of MODY have autosomal dominant transmissions. Less frequently, autosomal recessive versions are also exist, and they account for neonatal diabetes, they say. Next. Okay, so we have initially the types of MODI, they have classified up to 1 to 6, but now we have up to 14 types of MODI. There are now, we have at least 14 different known MODI mutation, including all these genes. GCK means glucokinase, like that. All these genes are involved, single gene mutation. So each one represents one type of MODI. Next. So I like to exhibit a few common types of MODI. So the common types are, I hope this is very clear, that's type MODI type 3 is it's very compared to the other types, 30 to 60% of patients accounts for MODI type 3. The defect is hepatocyte, that is mutation in the hepatocyte nuclear factor 1 alpha, HNF1 alpha. So that is related to MODI type 3 and is considered as most common compared to the other. So MODI type 1 having the genetic that means mutation in the gene encoding this HNF4A, and MODI type 2 glucokinase. So and also MODI type 5, the gene mutation in hepatocyte nuclear factor 1 beta. So these are we have various types from 1 to 14. These types are considered as common presentations. Next. So among these, the 30 to 60% MODI type 3 is somewhat common. So the HNF1A and HNF4A mutation. So that I told you, this HNF1A around 30 to 60%, this is around 30 to 40%. So these two gene mutations which representing the MODI types of MODI is common, and it is mainly exhibited in adolescents, and it has an increased sensitivity to sulfonylurea. So using low doses of sulfonylureas brings better control than metformin. So the ultimate idea, what I have understood from various articles, is that we have to go for suppose in case of any inconclusive in the diagnosis of diabetes, to categorize which type, like, and also to categorize the type of diabetes, we have to think in terms of monogenic diabetes, and we have to ask for the relevant genetic testing. So that plays a major role. So that will give us a clue or a guide us to choose the line of treatment. Next. Next. Okay. So previous one. Yeah. So the evaluation. So how to evaluate the patient. So the evaluation of patient should first start a diagnosis by ruling out the diabetes mellitus type 1. How to rule out type 1 diabetes by ruling out the presence, testing for pancreatic autoantibodies. We have listed out so many autoantibodies. If the autoantibodies are negative, then yes, by that particular test, we can rule out the type 1 diabetes. But particularly in glucokinase related gene mutation associated MODI type, we have to check HbA1c, fasting plasma glucose level can be very helpful, as they typically fall within specific ranges. That is very, very important. So in this GCK, that is glucokinase related mutation type MODI, the fasting plasma glucose generally falls between 99 to 144 milligram per deciliter, and HbA1c between 5.6 and to 7.3. Next. Yeah. They have, in some articles, they have given some markers, biomarkers for monogenic diabetes. There they have shown the importance of high sensitive CRP. So high sensitive CRP is another surrogate test that can help to distinguish the HNF1A MODI from other types of diabetes. So this value will be lower in HNF1A MODI, that is MODI type 3. Next. So these are the markers. These are the markers, that is biomarkers for monogenic diabetes. They have said the standard biomarkers are fasting C-peptide, random or glucagon stimulated C-peptide, and autoantibodies. The proposed biomarkers are serum 1,5 and hydroglucitol, and high sensitive C-reactive protein, and urine C-peptide and creatinine ratio. Next. Okay, who should be genetically tested for MODI? So the genetic testing for MODY should be done in cases where there is high index of suspicion that the patient doesn't have type 1 or type 2. That's what I told you in the previous discussion. So if we are inconclusive about the diagnosing the patient as either having type 1 or type 2, that time we have to think in terms of the monogenic. I'm not pertaining towards MODY. We have to think in terms of monogenic diabetes. But of course, neonatal diabetes usually presents in the patients below 6 months of age. Out of course, we have to think in terms of MODY, any type related to the patient's clinical signs and symptoms. We have to ask for the relevant genetic testing. And also genetic counseling is very, very beneficial. It's very, very important among the patients, among the family members of the patients who are diagnosed to have MODY, any type of MODY. Next. So the same thing will be repeated. So what are the indications for genetic testing? Patients with strong family history of diabetes presenting in the 2nd to 5th decade of life, leanness, autoantibody negative. So negative for autoantibodies, and futures inconsistent with type 1 or type 2, like low renal threshold, a large increase in plasma blood glucose in OGTT, and lower than expected CRP levels. Next. So this thing continues, lower than expected HDL cholesterol, high insulin sensitivity, and children diagnosed with diabetes mellitus 1 who are antibody negative and exhibit elevated C-peptide level. So that's what, again, I'm repeating the same thing. If we have any inconclusion in diagnosing or categorizing the patient as type 1, so that time we have to think in terms of all these parameters, and we can imply or impart the use of some biomarkers, available biomarkers, and also we have to go for the genetic analysis. Next. Okay, so the genetic analysis means molecular diagnostic testing only. So that will help us to identify the mutation, which gene is involved, which gene is mutated. So according to that, we can categorize the type, which type the patient belongs to, type 1 or 3, like that. So accordingly, we can plan for the treatment to the patient. Next. Okay, next. So what is precision diagnosis? Ultimately, accurate genetic diagnosis and to optimize the treatment. That means we have to, with all the various slides and discussions, finally, what we are trying to tell is we have to go for molecular genetic analysis in case if we have any suspicion about the presence of monogenic diabetes in a patient. This is to mainly fix the treatment plan for the patient. So in case of mutation or the MODY type 3 and 1, switching from insulin or metformin to low dose sulfonylurea. So this was, I was telling in the beginning slides, that is the patient was misdiagnosed having type 1 diabetes and the patient is on insulin treatment, but the patient won't be responding for that. So that time this genetic analysis will help us to identify the patient as any of the type of MODY, and we can decide the treatment part. Okay, next. So what are the advantages of this precision medicine? So the accurate monogenic diabetes diagnosis leads to it predicts the clinical course, and also it can assess the familial risk management. So that plays so here only the precision medicine, the role of precision medicine plays a role. Next. So those with MODY have diabetes characterized by young age at onset, that is between 10 to 45 years, autosomal dominant family history, continued production of endogenous insulin, absence of beta cell autoimmunity, and absence of signs of insulin resistance. Next. And also neonatal diabetes, any babies, newborn babies is found to have hyperglycemia related, signs and symptoms related to diabetes mellitus. We have to think in terms of neonatal diabetes, and we have to confirm the same by doing some genetic analysis. Next. So these are my references. And finally, what I would like to just convey is precision medicine mainly aims to go for a proper diagnosis and also properly classify their especially in case of diabetes, which type the patient is, which type of disease. Type of disease means which type of diabetes, whether it is type 1 or type 2, and we can exclude our type 1 or type 2. And if it comes under monogenic diabetes, we can fix the patient is having this particular gene mutation, and we can go for the correct line of treatment. So that is the idea behind the precision medicine in diabetes. And this doesn't end with this. We have lots and lots to learn about this monogenic diabetes, I say. Thank you.
Excellent and wonderful talk about the diabetes mellitus classification as well as related investigations, particularly mainly neonatal diabetes and the MODY types. So these related informations are more new for us. So in future, if you're going to treat the patients, if there any failure in the treatment of the either with the insulin or oral diabetes drugs, so these are the ideas, and the behind the investigation maybe give the more eye opener for the practicing clinicians. So it's a wonderful talk. Any questions from the floor side, please ask. Any profile available for the MODY diagnosis gene available or not? MODY profile available to diagnose the MODY related variety of
Yes,
genes.
sir, the molecular genetic diagnostic technologies are available to fix the type of gene that is involved.
Okay.
That is available, sir.
Available.
With those types of techniques only, we are able to diagnose and fix the type and plan for the treatments.
So in our area, it's available in our region.
So it's available in many laboratories, but it's not available in our setup, sir. In forthcoming years, our government is trying to implement this thing, sir, genetic laboratory in Madurai and also in Coimbatore Medical College Hospital, sir. So I hope so in near future, we might start the genetic clinic and also genetic lab in our institution. Thank you.
Okay. One more basic doubt. The fasting blood glucose, so when we taken it's maybe 6 to 10 o'clock morning.
No, sir. Fasting always we have to have 8 to 10 hours fasting. That's a must. That's
it's
a
not
must.
a time. Okay,
Yes, sir. Yes,
right.
sir. 8 to 10 hours. Minimum 8 hours fasting is a must.
Oh, great. Any questions? Thank you very much, madam. Thank you.
Thank you, sir. Thank you, ma'am. We have got a great understanding. Now I call upon the chairperson, Dr. L. Madan, sir, to felicitate the speaker. Thank you, sir. Now I request Dr. Sarun, sir, to felicitate the chairperson.